Okay, Bismillahirrahmanirrahim. Assalamu alaikum. Please, lights, if you can, you'll be able to see better if you just, yeah, that's it. Thank you. The slides are not moving.
Yeah, the buttons. Right.
This one?
Yeah.
Okay,
Right.
thank you. Okay, so last time we did these three upper conditions like stone, renal infection, and some congenital anomalies. Okay, so today we are left with the last three, which is renal masses, trauma, and some miscellaneous conditions. So renal masses, before we go into the masses, we remember last time I said we left at this slide, which is actually a lesion inside the kidney. If you look at it, it looks like a cyst. You see, if you measure the Hounsfield units, it'll be around water. If the Hounsfield units will be around between 0 to 10 or around, water Hounsfield units. So the history on this is a 55-year-old male with ultrasound track showing, after urinary tract infection, he has a cyst measuring 3.5 centimeter in size with an internal septum. So if you look carefully, you can see a thin sort of septa inside, this septa inside, which shows some sort of enhancement after contrast. So now the question is what to do with it. There's a cyst of 3.5 centimeter size, and there's a septa also that is lying within the cyst. So it's not a sort of very simple cyst that you see, that means just containing fluid inside and that you can leave it alone. So what would you do with it? So anyone? Still leave it. Good answer. So why would we leave it? Because we need to have some sort of scientific, you know, justification when to leave and when to sort of follow them up or when to sort of remove or excise them. So Bosnick, American surgeon, was the one who gave us this classification. It's still being followed with little modifications considering the MR that is now available to us. But the basic concept remains the same. Bosnick 1 and 2 are the benign cysts, which can be left alone. Bosnick 3 and 4 are the cysts which are considered as pre-malignant because they have potential of malignancy. And Bosnick 2F, F itself means follow-up. So 2F means follow-up. This means that these cysts need to be followed up. Why? Because they still have a potential of malignancy. They can, if they remain stable over a period of time, say 6 months or 1 year, then you can leave them alone. So, but you still need to follow them up. So what is a Bosnick 1? A simple cyst like a fluid containing cyst. You measure the Hounsfield units, it's around, say, around 0 or below 10, you leave it alone. If you see a septa inside like this, a simple septa, which might be enhancing, but the thickness is less than or equal to 2 millimeter, you can again leave it alone. Sometimes, some we'll talk of this later. The third one is a cyst containing 3 or more septas. 3 or more septas, and the thickness should be any septa having more than 3 millimeters thickness. So then it means it should be a Bosnick 2F. You cannot just simply, say it is benign then. If you have 3 or more septas and some septa or even a one septa which is more than 3 millimeter thickness, then you need to consider this as a Bosnick F and you need to follow them up. Whereas Bosnick 3 and 4 is a septa with thickness 4 or more than 3 septas, then obviously it is Bosnick 3. Bosnick 4 means along with the septas or without even with the septas, you can have a solid nodule enhancing inside. So what you're doing is you're doing a plain study and you're doing a post-contrast study and you see some enhancement inside the cyst, which is solid. You call this as Bosnick 4, okay? So let me make it more easy for you with this picture. Bosnick 1 means a simple cyst like this. Bosnick 2 means 1 or 3 septa. So not more than 3 septa, and the thickness should not be more than 2 mm. Bosnick 2F means 3 or more, 1 or more 3 millimeter septa. Okay, so that means more than 3. 1 septa can be more than 4 septa with less than 2 millimeter thickness. So that means we are taking 3 millimeter thickness as the cutoff point. If it is above that, above 3 millimeter thickness, then it falls into Bosnick 4. Here you see 4 millimeter. So if you just remember this criteria, you'll be able to differentiate 3 and 4 and rest. So remember, if you have a septa which is 3 millimeters, or below that, that means it is going to be 2F. If you have a septa thickness more than 3 mm, it's going to fall into Bosnick 3. And then it is, chances of malignancy increases. So remember this, 4 millimeter or more thickness septa, or the number is 3 or more, number of septas, then it is Bosnick 3. 4 is easy. You have a solid enhancing component like this, and then it is 4. So these are the ones which are worrisome, and you need to, either take a decision on when to sort of remove them. Now let's see a few examples. This is a cyst with some specks of calcification. So is it Bosnick 1? Yes. Bosnick 1 means just a cyst without any finding, a simple fluid containing cyst. So if you go back, you see, this is 1. So if you have a speck of calcification somewhere like this, it's going to be Bosnick 2. Remember, if a cyst has high density like this, sometimes the fluid is not simple fluid, it is proteinaceous fluid. So when you measure the Hounsfield unit, it is more dense. So that at times is known as high density cyst. But again, it would not enhance. When you do a post-contrast study, it would not enhance. So a big cyst would be follow-up. Some big cysts with high density material might still need follow-up. So high density cysts are not necessarily considered as malignant. So they don't fall into category 3 and 4. If they are big, you might need to follow them up. Okay. So this one is a thin septa with some enhancement. So what do you think it is? 2. Very good. What about this one? 3 or 4? 4. So when you have a solid enhancing component, a nodule like this in the wall, it is 4. A thick septas, a network of septas, 3. So this is how the 3 looks like. So you cannot just sit on this lesion. Sometimes you would have a Bosnick 1 again, simple cyst. But sometimes a cyst can have solid components in the wall like this. So this is category 3 or 4? 4. Very good. This is a renal cell carcinoma. Sometimes the renal cell tumor it's obviously a solid tumor, but some areas might not enhance like this. So these are actually the necrotic areas, which look like cystic areas. They are not actually cysts. These are some portions of that solid tumor which have necrosis, and therefore they do not take up contrast. So this is actually a tumor with necrosis. So this area, don't mix this up with a cyst or a cystic lesion. Again, another tumor with some area which is not enhancing like this. So a tumor at the lower pole, but you have a solid component in this. So you can consider it as a Bosnick 4 or cyst with a Bosnick 4 with solid component. Or this can also be sometimes a renal cell carcinoma with necrosis. But remember, the necrosis is usually with larger tumors. When the tumor grows is very much enlarged in size, then some portions undergo necrosis. So this is another example of a renal cell carcinoma, a solid enhancing lesion. This is not a cyst. And what about this kidney? Does anyone know what shape is this? Horseshoe. So the kidneys, if they are united in front of the spine, this is horseshoe kidney because the kidneys usually ascend in embryologically. So if they remain in the pelvis or in the lower part of the abdomen, that means they sometimes remain, they unite in front of the spine. So abnormal axis of these kidney, they are prone to infection and stone formation. Can also have tumors growing inside them. Okay, multicystic nephroma, remember, is a condition which is considered as benign with very less chances of or less potential of malignancy. So they have these two peaks either in children below 5 years or above 40 years. So this is the age group where you would see multicystic nephroma. Remember, these are cysts, a larger cyst, and you would see smaller cysts within a cyst. So giving you a smaller cyst lying within a larger cyst. This is how it looks like, a smaller cyst within a larger big cyst. So sometimes they appear as a bunch of cysts lying within a larger big cyst. So remember the age, and sometimes don't mix them up with the other lesions. They are considered as benign lesions. Okay, this is a solid tumor. By far, the more common one is renal cell carcinoma. 90% of the renal tumors, if you have a tumor in the kidney, it's going to be renal cell carcinoma. And it is 1 to 3% of the other visceral tumors. And male predominance, 3 ratio 1. So this is a solid lesion. Some part is not enhancing. Why? Because this is necrosis inside this tumor. Another example, the same case I showed you earlier on, the cystic part is not enhancing because it's not a cyst, it's necrosis in the tumor. Now, the same patient has an IVP and there's distortion of the calyces here. So remember, renal cell carcinoma it's a tumor which is arising from the renal tissue itself. So it will result in displacement of the collecting system. It is different from urothelial tumor, which arises within the collecting system and would result in a filling defect or cutoff of the collecting system. Remember, renal cell carcinoma is arising from the tissue itself, the renal tissue itself, and would push and displace the collecting system. Whereas the transitional cell or urothelial tumors, they arise within the collecting system. So they'll just sort of have a filling defect. They'll not result in a bulge in the kidney. So what you see is sometimes a large lesion like this, a contour bulge. You see a bulge in the kidney like this, displacement or amputation of some part of the calyces. So they'll be pushing upon the calyces. They'll be stretching of the calyces. And sometimes they can also result in obstruction or mild hydronephrosis or dilatation of the calyces. So, you would see some clubbing of the calyces. Another example of renal cell carcinoma with central part which is not enhancing because of necrosis, central necrosis. Okay, so now the problem is when you have a solid mass picked up on ultrasound or IVP or whatever initial investigation, then you need to stage it. And the best imaging modality is CT and MR to stage these tumors. Why? Because you are able to see the lymph nodes, you are able to see the local invasion, you are able to see whether there is extension inside the renal vein and IVC. So that all contributes to the staging. Now let's see a few examples of this. So what we are looking for is a tumor which renal vein invasion, IVC invasion, perinephric invasion, lymph node enlargement, adrenal metastasis. So if it has gone to the adrenals or it has locally invaded the other viscera, then it is obviously a advanced stage 4 tumor. So another tumor in the left kidney with some areas not enhancing because of necrosis. Now let's see this example, renal cell carcinoma with venous invasion. So you see there is this tumor which is going inside the renal vein. This is the aorta, and this is where the IVC should be. So it's not enhancing like like the aorta you see here. That means the tumor thrombus has extended inside the IVC. You can see this here. The rest of the IVC looks fine, but this portion of the IVC has a thrombus inside. So renal cell carcinoma invading the renal vein and IVC. So when this happens, it means stage 3. Another example of a tumor, very large tumor, when it becomes large in size, as I've said, the chances of necrosis, the portions of the tumor, the necrotic areas increase in size. So this is the necrotic part. This is a solid component. Sometimes you could have bilateral tumors, but this one is going to the adrenal on the other side. And you could also have sometimes secondaries inside the liver. So this is the liver. So this is an advanced tumor where it has gone by hematogenous spread to the adrenal on the contralateral side and to the liver. Okay, and you can see that there are a few lymph nodes as well. Okay, some necrotic lymph nodes as well. So this is what I've just said. Invasion of the adrenal gland, IVC, as well as metastatic extension to the liver, to the other kidney and adrenal gland. So when it becomes advanced, it can go anywhere. It can go through hematogenous spread. It can go through local invasion to whatever, whatever area it is accessible. It can go to it can spread to that. But obviously, this is stage 4. Now, why is it important for the size? Because the surgeon, if it's a small tumor, less than 3 centimeter in size, the patient can be, some part of the kidney can be saved. He can be offered partial nephrectomy. For example, if the tumor is at one pole, one upper pole or lower pole, so the patient, the surgeon would, just remove part of that area of the kidney where the tumor is lying, and rest of the kidney can be left alone. But for it to be partial nephrectomy, it should not be lying centrally. It should not go inside the sinus, renal sinus, or should not be close to the vessels. And obviously, the size does matter. Okay, so for a surgeon to have it excised, less than centimeter size, lying at the poles, the patient can still be saving some part of the kidney. But if it goes into the renal sinus collecting system, renal vein invasion, lymphadenopathy, distant metastasis, then despite if the size is small, still you cannot offer any, then you cannot offer partial nephrectomy. Now, just to see this is what I've just mentioned. If the tumor lies within the renal tissue itself, it is stage 1. Okay. If it lies or goes beyond the kidney contours up to the capsule of the kidney like this, then it is stage 2. If it goes into the IVC or the renal vein, then it is stage 3. And obviously, lymph nodes are also going to be upgrading it to grade 3. So remember, grade 3, if you remember grade 3, then it becomes easy. Renal vein invasion or lymph node involvement is stage 3. And stage 4, you already know, if it goes beyond the Girota's fascia. Remember the last lecture I showed you the fascias around? So the disease process is limited by these fascias that are around the kidney. So if it goes and crosses the Girota's fascia, it is stage 4. That means it's locally spreading to the adjacent organs, or it has metastasized to the lungs, to the bones, or to the adrenal or the other kidney, then obviously it's stage 4 again. So remember, within the kidney, stage 1, within the capsule, stage 2, renal vein or lymph node enlargement, stage 3, and if it goes beyond the Girota's fascia or other organs, stage 4. So stage 1, a tumor within the renal capsule. Okay, small, less than 3 centimeter size. Okay, so this is stage 1. This is stage 2. Again, a tumor with some areas of necrosis, but it goes into the perinephric area, but does not cross the Girota's fascia. It remains within the perinephric fat. Okay, so this is stage 2. Stage 3, as I've said, lymph nodes or IVC invasion or renal vein invasion. So these are these large, enlarged para-aortic lymph nodes. These are all lymph nodes. So stage 3. Again, you can see necrotic tumor here with some the rest of the tumor is enhancing. This is the necrotic part which is not enhancing. Compare it with the plain study here. This is the plain study. This is the post-contrast study. Stage 4 is when it crosses the Girota's fascia or invades the adjacent viscera, like this is the liver on this side. So you see there's a lesion in the liver as well. So this tumor has locally spread into the liver. So when it crosses the Girota's fascia, it is stage 4. Okay, sometimes these are these cystic renal cell carcinomas. This is a variety of renal cell carcinoma, which has cystic predominant component. And it is at times difficult to differentiate it from Bosnick 4 because that also has a cyst with some areas solid component with it. So this is a cyst with some solid component, again, cystic lesion with cystic and solid component, again some solid component enhancing with the cyst. So these are cystic renal cell carcinomas. It's just the appearance, and it becomes difficult at times to differentiate it from Bosnick 4. You see, this part of the cyst is taking up contrast. Again, this part of the cyst has solid nodule here. You see, this is solid nodule, rest is cystic. Again, a solid nodule here, and rest is cystic. So again, just to tell you that these are malignant, but at times you cannot differentiate it from Bosniak 4, which obviously is also malignant. Nephroblastoma or Wills tumor is a tumor of childhood. Usually see it below 3.5 years of age. And the problem with this tumor is that usually they grow large in size when the child presents. The parents notice this mass. It's too late. The tumor has already metastasized to the organs, to the lungs, or to the other viscera. So then it becomes very difficult. And sometimes unfortunately they can be bilateral. So it can be on both sides, both kidneys. So remember this, a large tumor in the kidney, you have to differentiate it from neuroblastoma, which is a tumor from the adrenal gland. Obviously, both are lying very close to each other. So if they become large in size, then it becomes very difficult sometimes to just by looking at them, is it an adrenal gland or is it a kidney? So then you have to make use of imaging, where in imaging, you would be able to see a rim of tissue around it. If you see some rim of tissue or renal tissue around it like this is known as claw sign. Some portion of the tumor is surrounded by renal tissue. That means it is arising from the kidney itself, and the rest of the renal tissue is surrounding it. Let me show you a few more examples so that I can make my point clear. So this is a large tumor on X-ray. You can see that the bowel is displaced by this large tumor. And once you do an ultrasound, you'll see a solid lesion like this. And again, a solid lesion with necrotic areas in this kidney, that is the right kidney, and this is the normal kidney on the left side in a child. Once you do a CT scan, you will see some renal tissue around it like this. You see, there is some renal tissue around it. And then this is the whole tumor. Again, a big tumor mass, and you see some renal tissue around it. This is known as claw sign. The claw sign it tells you that this is arising from the kidney. If it is an adrenal tumor, it will displace the kidney. So the kidney would be either pushed to one side or would be pushed low in the abdomen. So because obviously adrenal is lying at the top. So when you have a mass coming from the adrenal, it will displace the kidney rather than you would see some rim of tissue around it. So whenever you see this rim of tissue around a big mass like this, that tells you that this is arising from a kidney. Okay. So claw sign is significant. And if you see this, that tells you it is a renal tumor rather than an adrenal tumor in a child. Remember, both are going to take very large sizes. So it becomes difficult to tell where it is coming from. Okay, sometimes you would have renal lymphoma, another tumor in sometimes affecting the kidneys. But the clue in this case is you look at the other structures, like look at the large lymph nodes. Sometimes you would have lymph nodes enlargement with the renal lymphomas, or lymphomas can also result in splenomegaly and can have, because these are lymphoid tissue, so you would have the lymphoid tissue also affected with this. So you would see a lesion in the spleen as well. Sometimes could have bilateral masses. So if you see bilateral masses and lymph node enlargement or splenomegaly or lesion in the spleen, then it is going to be lymph nodes. So these are lymph nodes which are encasing the mesenteric vessels here. These are again lymph nodes here. So another clue would be immunocompromised patient. Lymphoma patients are likely to be immunocompromised. So retroperitoneal bulky nodes like this are a clue for lymphoma. So again, bilateral masses. Don't think these are cysts. They look like cysts, but actually when you measure them, they have enhancement. So these are bilateral renal masses, and these are retroperitoneal lymph nodes. Again, a lesion in the liver, a lesion in the spleen, a lesion in the stomach. So all lymphoid tissue get affected. See, lymph nodes. So sometimes bilateral renal masses, think of lymphoma. You could also have these retroperitoneal bulky lymph nodes encasing the aorta like this. You see, this is aorta looks like sandwiched. It's sandwiched in between these lymph nodes. So this is a large nodal mass. Sometimes they are also undergo necrosis like this. With treatment, they can undergo necrosis. So again, a nodal mass, renal lymphoma. Renal lymphoma affecting both kidneys. You see solid mass here enhancing, another mass here. So bilateral masses. This is an AIDS patient. Okay, another tumor which is benign is angiomyolipoma. So angio means something from the vessels. Myo means from smooth muscles. Lipoma means fat. So it has all these three components to it. It has vascular component, has soft tissue component, and the third is the fat component. But remember, the fat component is the more important one, because once you see this lesion, it has the fat component stands out. So you see this is low attenuation here, very similar to the perinephric fat here. Again, this is a lesion with fat here, very similar to the perinephric fat. So once you see fat inside a lesion or a tumor, you think it is going to be a benign lesion, more likely to be angiomyolipoma. But that doesn't mean it's just always going to be angiomyolipoma. It can also be a lipoma, can also be a teratoma, liposarcoma. And in the last lecture, I mentioned xanthogranulomatous pyelonephritis, which is a type of end stage sort of nephritis where the macrophages engulf, they have lipid laden fat inside. So these macrophages have fat in them. So once you measure the Hounsfield units there, they also give you appearance of fat. So this is the differential, but by far the common benign tumor that you see with fat is going to be angiomyolipoma. As long as they are less than 4 centimeters in size, you just leave them alone. But if they become large in size like this, more than 4 or 5 centimeters, then there is a concern of anyone? Sorry? No, they don't turn malignant. Yes. Anyone? What would happen if a lesion gets large? Hmm? Compression, okay, but what did you say? Bleeding. Why would they bleed? Because these are tumors coming from the vessels. They have leaky vessels. They are not normal vessels. They don't have normal vessels. So chances are when they become large in size, the pressure increases and these vessels are prone to rupture. So you have to be careful with the larger lesions like this one when it becomes more than 4 centimeters in size, because these are leaky vessels. They are not normal vessels inside these tumors. So you see there is perinephric collection or hematoma around them. This is a small tumor. As long as they are small in size, you don't do much. The problem is a condition known as tuberous sclerosis, which has multiple sort of angiomyolipoma. So you'll see multiple lesions in both kidneys. Now, what to do with them? If you have multiple lesions, obviously you cannot remove both kidneys. If you have a lesion in one kidney, you can remove that kidney, and obviously the other kidney would compensate or still live with it. But the problem, if you have bilateral tumors, then it becomes difficult. Then you need to make decision. If the lesions are larger in size, then you might just need to do embolization just to save, some part of the kidney function. And so partial nephrectomy becomes difficult if you have bilateral tumors. So another example of an angiomyolipoma, but again, there is fat. If you look at the perinephric area, there's collection around this. So this is a bleeding tumor. So there's perinephric hemorrhage around this tumor. Okay, the last tumor that you see is the transitional or urothelial tumor, which is tumor, as I've said, arising from the collecting system. You see, this is upper part. You don't see contrast here. Likewise, you don't see contrast in the lower part of this ureter. So remember, they are sometimes multiple in you sometimes see it on the upper collecting system. You can also see the same transitional cell carcinoma in the urinary bladder. So they would be multiple lesions, which gives you a clue. Another important clue is to look at the enhancement. If they do not enhance, then again, it shows that this is a urothelial tumor rather than a renal cell carcinoma. Renal cell carcinoma is more vascular, so it would enhance with contrast. Okay, so if you see a filling defect in the pelvis or anywhere in the collecting system, then it can be transitional cell carcinoma. Okay, you have to differentiate it from renal cell carcinoma. As I've said, renal cell carcinomas are vascular, so they'll take up contrast. So you look at this example, this is a pre-contrast study without contrast, and this is with contrast. So you see this part is not enhancing. So once we did a IV on this, you see that the upper collecting system is sort of blunted. There's a filling defect. So obviously there's no contrast going to the upper part. You can see the normal lower callaceal system. So when you have a filling defect like this in the upper collecting system or renal pelvis, then think of urothelial tumors rather than renal cell carcinoma. Renal cell carcinomas would just push upon the collecting system, will not give you a filling defect inside the collecting system. Here you see a filling defect inside the renal pelvis. Another example of filling defect inside the renal pelvis. And you see some portion is enhancing, some part of the tumor thrombus is extending into the renal vein. Another example of, sorry, not the renal vein, renal pelvis. This is an example of renal pelvis with thrombus or tumor extension or tumor inside. This is the plain study. This is the post-contrast study. You can see that this is not enhancing. So this helps you in, one is the location inside the collecting system. The other is the poor enhancement, which helps you differentiate from renal cell carcinoma. If they are small like this, then you have to put other differentials like blood clot, polyps, hypertrophied slough papilla. So this all comes in the differential if they are small in size. Okay, so the last thing that remains, sorry, the second last is the trauma cases. So what do you do with the trauma cases? Remember, it depends on, initially, remember the investigation of choice is going to be CT. Why? Because it gives you more detail. It will help you in staging of the trauma, what to do with this patient. But sometimes it's not that easy. If you look at this example here, you see the kidney is sort of split into two. The upper portion is here and the lower portion is here. So what is it lying in between? What do you think this is? Is it a tumor? Different patients involved in motor vehicle accident with blunt trauma to the abdomen. Okay. So this is going to be blood. So that means the kidney is sort of lacerated in between. So there is an injury to the kidney and there's blood which is sort of splitting the kidney into two. Now, if you look at the other example here, again, there's blood around this and there is active extravasation of contrast. So that means once you give the contrast, it's in the aorta and in the collecting system, but it is also coming out of the kidney itself. So that means there's a vessel which is leaking. There's extravasation. The contrast is not lying inside the kidney, it's coming out or leaking out. So this tells you that there is active bleeding which is going on. Now look at this example now. This part of the kidney is enhancing, but the rest of the kidney is not enhancing. So this means this is devascularized. So the blood supply to this portion of the kidney is lost. There's no blood supply to this part. That is why it is not enhancing. So devascularized. Now let's see what this all means. If you have a subcapsular hematoma like this, it's stage 1. If you have a subcapsular hematoma like this with 1 centimeter laceration in the cortex, stage 2 or grade 2. If you have a subcapsular hematoma with more than 1 centimeter deep laceration like this, going deep, then it is grade 3. So, or remember, grade 1, 2, and 3 are just leave alone. You'll just sit on them and you'll just sort of give them supportive treatment. Now, grade 4 and 5 are the more concerning ones. Why? Because obviously the laceration has gone deep into the renal sinus and there can be urinoma formation or they can be active and there can be some hematoma, localized hematoma, and there are chances that these patients might bleed inside. Okay. But this one is known as shattered spleen, where it is, sort of broken into multiple pieces. So this one is grade 5, and this obviously cannot be saved. So the surgeon would sort of remove this kidney because he cannot go in and, uh, replace the kidney or tie them up all together. It's impossible to, stop bleeding from such kidney, which is sort of shattered or devascularized. So shattered kidney, devascularized kidney, or hilar revulsion is when you need to go in surgically and clamp that artery or vessel which is bleeding because the patient is going to lose blood inside. So remember the trauma patients, when they present, the best thing is to do an ultrasound just to see if there is fluid inside the peritoneal cavity. If the patient is stable, you can ask for a CT scan immediately and do a CT scan just to see if there is renal injury or any other visceral injury, because it will give you a broader picture. If the patient is unstable and by ultrasound you detected free fluid inside the abdominal cavity, that means the patient is losing blood. So you cannot send him to CT or any other department just to have to collapsing in the CT scanner or anywhere else. That means you are trying to save the life. Then you have to immediately shift him to the OR because obviously he's bleeding inside. Even if you rush fluids or give him blood transfusions, he'll keep on wasting. The blood is going to come out and out, and he'll collapse somewhere. So It depends on what the condition is. If the patient is unstable, you don't need to send him for CT scan. Go directly from OR, ER to OR. Okay. But this one, the stage 4, where you have a laceration of the renal cortex going into the collecting system, minor renal artery or vein injury with a contained hematoma. So he's not actively bleeding. He's stable hemodynamically. Then you can ask for a CT scan. Okay. Whereas grade 1, 2, and 3, you just sit alone. You don't do anything with these because you just need to give bed rest, analgesia, prophylactic antibiotics for grade 1, 2, and 3. Okay. So grade 4, 5 depends on do a fast ultrasound in detect free fluid, shift the patient to OR if the patient is unstable. If the patient is stable, there's no free fluid in the peritoneal cavity, then you can ask for a CT. And obviously, it'll give you a staging of the trauma or injuries in the rest of the viscera. Sometimes you could also have fluid collections, localized fluid collections like this. This is known as urosepsis or pyonephrosis. These are infected urinomas. So sometimes extravasation of urine from trauma can get infected like this. So these are examples of urinomas, okay? So what you do is if they get infected, obviously you put a drain inside. You put a pigtail catheter, which drains these urinomas. That's it. Just wait on them. Okay, so now let's put this all together. Obviously, it's not that easy. Sometimes, the CT picture becomes very much, with experience and with the expertise, you are able to differentiate. But if you know what these four are, it will make your life, it'll probably make more sense to it. So let's start off with this. The normal right kidney. What about this kidney? There's a defect here. And if I give you a trauma history, then what would you think it is? What do you think is going on? There is a laceration. There's a laceration, deeper laceration with perinephric hematoma. And obviously, trauma history is going to be there with it. What about this one now? Look at this kidney, looks normal. What about this kidney? Again, looks normal. There is no laceration, but there is fluid around it. So what do you think it is? Again, there's localized fluid correction. If I give you history of trauma, this can be urinoma. If I don't give you a history of trauma, then that means it can be any other collection. It can be because of any infection. Okay, so this is, but there is, the kidney looks normal. Why? Because there's normal enhancement here. What about this kidney? Does it look normal? No, it doesn't look normal. Even this kidney doesn't look normal. They see there's some patchy sort of striated appearance here. And if you remember the striated pattern that I mentioned in the last lecture, it was pyelonephritis. So this is an example of infection inside both kidneys. And this is more likely to be a fluid which is infected. So more likely to be a pyocele or, infected urinoma or whatever. It's all infected. And you see the enhancement is also not that great. Not unlike this enhancement pattern that you see here. See, compare this enhancement with this enhancement pattern. This is an example of pyelonephritis, bilateral pyelonephritis. Now, this is a little tricky. You see there's a lesion in the left kidney. Compare this normal kidney. Compare this kidney. There's a lesion here, which is sort of going into the mesentery. There's these low attenuating areas, which are sort of encasing the aorta. So does it? Yes? Lymphoma. He's right. This is a lymphoma. When you have the aorta encased by a solid mass or a lesion like this, you see the mesenteric vessels are all encased. So this is known as sandwich sign. Sandwich. It's just like a burger, the patty being sandwiched by the burger. So you see the aorta, the IVC, the mesenteric vessels, or encased by a low attenuating mass, which is feature of lymphoma. So these are all lymph nodes. Actually, they are all matted together. Okay, now let's talk of, I think I showed you this in the last lecture, the urinary bladder common lesions that we should know of. So when you have a lesion arising from the wall, the common one is going to be, which one? What tumor arises from the transitional cell? The urothelial tumors. So this is the transitional cell earlier on, and this is the later stage when you have a large sort of mass inside, okay? You can also have some calcifications associated with this. So this is a transitional cell advanced stage. This is an early stage tumor. What is this when you have a diffuse sort of thickening of the urinary bladder? Cystitis, okay? So this is an example of cystitis. And if the cystitis keeps on, it becomes chronic like this, it gets calcified. So what is this condition? Usually when it gets calcified, usually in infections. So I told you an example of parasitic infection, schistosomiasis. So schistosomiasis can result in chronic infection involving the wall of the unibladder and gets calcified like this. Okay, so prostate is also part of the genitourinary system. So just the common things. Remember two things that you should know of. One is tumor and the other is BPH. Okay, so remember the tumor in the prostate is by far the majority of the tumors would be lying in the peripheral zone. So this is how the T2 weighted image of prostate looks like. The outer zone is brighter like this, and the inner glandular part is low signal like this. So you can make out two portions of the prostate gland, the central part like this, and the outer peripheral part like this. So where does the tumor usually, in majority of cases, lie? Peripheral part. So this is the peripheral part. So this is the peripheral part. So this is a T2 weighted image showing you a rounded lesion in the peripheral part. So obviously, the prostate cancer is more likely to be in the peripheral part. If there is enlargement of the central part like this, it's hyperplasia. It's benign prostatic hyperplasia. So you see there's stretching of the outer part like this. So there's more of the glandular tissue growing and replacing it'll be hard to see the peripheral part because all of is occupied by the glandular tissue. So these are the common things that you should know of. But sometimes even in the peripheral part, it becomes difficult to differentiate if there's focal sort of prostatitis, some inflammation, chronic inflammation or acute inflammation of the prostate. It can affect any part of the prostate. It can be affecting even the peripheral part. Then it becomes difficult to differentiate on just simple, T1 and T2 weighted image. Then we take help of contrast and diffusion weighted imaging. So then it becomes multi-parametric imaging. So if you are confused whether this is prostatitis or prostate cancer, then you need to give contrast and do diffusion weighted imaging, which in MR is known as multi-parametric imaging. Then it helps you and to decide whether this is infection or this is cancer. Okay, but obviously at your stage you don't need to remember that. Just remember two common things: prostate cancer more likely to be in the peripheral part, BPH in the central part, the glandular tissue. This is how they look like. Okay, clear? Okay, testicular tissue also comes in the genitourinary system. This is how it looks like on ultrasound. This is the testes and this is the epididymis, how it normal looks like. Once you put flow, you have to make use of color Doppler, especially when you are trying to evaluate the testicular tissue. Why it is important? Because two conditions mimic each other. One is known as epidydmo-orchitis. This orchitis or epididymitis means inflammation of the epididymis. Orchitis means inflammation of the testicular tissue. So once you put color flow like this, you see increased vascularity in the epididymis or in the testes. If this is the finding, then it is more in favor of epidydmo-orchitis. Remember, in young people, especially children and young adults, the problem is acute testicular pain. So the OR is going to send you, sorry, the ER is going to send you a patient asking you what it is. Is it torsion or is it epidydmo-orchitis? So you just put ultrasound probe, put color, see the flow inside. If there is flow inside, it's more likely to be epidydmo-orchitis. If you don't see flow inside, that means it is torsion. So again, an example of epidydmo-orchitis. Sometimes you could also see fluid around it. This is reactive hydrocele, some fluid around it. Mm-hmm. I don't know what, they're just showing you the capsule. This is just to show you how I just wanted to show you how the testes looks like and where to find the epididymis. It'll be on one side of the testes, okay? So this is epididymis on one side of the testes, okay? Again, epididymis on one side, and this is the testicular tissue. But you also see fluid around it. So this is known as hydrocele. When you see fluid around in the scrotal sac, it is known as hydrocele. Now, this is an example of torsion where you don't see blood supply inside the testicular tissue. You see, it is low density, low echogenicity, and or when you put color Doppler, the flow is only at the margins, at the capsular part. You don't see flow inside the testicular tissue. So this tells you this is torsion. Okay. Obviously, on clinical examination, you can also make out torsion. Obviously, it's a very acute condition. When you lift up the testes, it's painful. Testicular, and the next thing to differentiate is abscess from a tumor. Okay. How to differentiate an abscess from a tumor? Abscess, obviously, it is sequelae or a follow-up with an infection. You had an infection or you had recurrent infections. Then there's a abscess forming inside the testes. Then how to differentiate? Remember, an abscess has necrotic tissue inside. So when you put again, use the color Doppler. When you put color inside, the necrotic tissue would not take up contrast. Okay. The necrotic part of the tissue would not, and they'll be just flow around at the margins of the lesion. Same here. The necrotic tissue is not taking up contrast. So they'll be just flow at the margins of the lesion. So this is an abscess. This is an abscess. Why abscess? Because the necrotic part is not vascularized. It will not take up contrast. Whereas a tumor would take up contrast. So if it's a seminoma or any other germ cell tumor, it is vascular, it will take up contrast. Another thing to remember here is this is a seminoma. Why? Because if you look at carefully, there are these tiny echogenic foci inside the rest of the testicular tissue. Does anyone know what these are? Few tiny echogenic foci. These are actually microlithiasis. So what does microlithiasis, testicular microlithiasis mean? Anyone? Tiny sort of calcifications, just name given to calcifications inside. They are multiple like this. So remember, there's an association of seminoma with microlithiasis. So they say if you find microlithiasis, the chances are that the seminomas developing with patients with microlithiasis increases. Just an association. So this is an example of a seminoma with microlithiasis. You see, and it can be usually on both sides, and it runs in sometimes in families as well. Okay, so what do you think this is now? You see, there's blood supply inside the lesion, and this lesion is lying inside the testicular tissue. So this is a seminoma. It's not an abscess. Why? Because as I've said, if the blood fills up the central part, or the necrotic tissue is not going to take up contrast. So in an abscess, the central part would not be showing you contrast. So this is an example of a seminoma. So just remember, in a young male patient from ER, you have to differentiate between torsion and epididymoarchitis. Okay, inflammation from torsion. If there is no blood flow, it is torsion. If there is blood flow increased, epididymoarchitis. In middle age or old age or even young, you can have seminomas. Okay, so seminoma is when you put color inside, the tumor or the lesion will show vascularity. It doesn't mean low vascularity or high vascularity. It makes no difference as long as it is vascular. But an abscess would show just enhancement at the periphery. Why? Because the capsule is, or the margins are going to is more inflamed. So they are going to take up contrast, but the necrotic part, which is in the center, would not take up contrast. And that is how you, and obviously you would have clinical backing with that. You see C-reactive protein, the WBC counts, and clinically the patient would have fever. So all those things together would help you make decision. Whereas a seminoma would have these microlithiasis, and the patient at times would be asymptomatic, just presents with an incidental mass. Okay. So this was the last slide. If you have any questions, you can always email me. Remember, the questions that are going to be in the exam are going to be from all these slides. They are hidden somewhere in these slides. Just go through them once more, and you'll be able to answer all questions. Okay? Okay, thank you very much. Sorry, tip for the exam? As I've said, just go through the slides, and some areas